before we move on to our last speaker, Ajay Kumar from Singapore, who will be talking on myopia control, a guide to customised treatment approaches.
Okay. Good morning to everyone, and thanks Mr. Jason for giving me the opportunity to over here. So I'm going to bring you a myopia control, a guide to customized treatment approach. I don't have any conflict of interest, and we all know it happens when the eyeball is too long, or it can be caused by overly stiff cornea or increased optical power of the lenses. So in the first biometry we can see is solely on the because of the axial elongation, but in case of the second biometry we can see the lens and the corneal curvature is the contributor for the myopia. So myopia, not all are the same, like so many people are asking about the ROP and whatever, but it's not all are the same, and the cause is the main implication for the myopia management. So we need to, so for each individual patient there could be one primary driver, so we need to look for what is the primary driver, and that makes the myopia such a fascinating area for research and the practice. So what we need to exclude for the standard myopia management, as we can look at here, if the lens is subluxated, microspherophakia, usually the lens thickness is more than 4 mm, and that could be the primary contributor for your myopia. Keratoconus usually associated with the irregular astigmatism, juvenile glaucoma and ROP baby, they all are associated with sometimes the progressive myopia. So careful examination of anterior segment examination should be ruled out all the cases. Coming to the syndromic, high myopia and pathological myopia, all of them associated with nothing else very early part of their life, just the high myopia. So we need to exclude for all these cases for your standard myopia management, because we don't have any evidence at this moment to treat these cases. Where it works, where we have the evidence of true axial myopia, it seems very simple, but it's the most important factor. Detecting the true axial myopia is like a puzzle where each piece is crucial to see the picture. So for the intervention of myopia progression, it's only the axial myopia where we have the lots of intervention options. And we all know these are the factors, either is associated with the onset and progress of the myopia. So we need to look for it. And these are the factors is not associated. Most of the research study has shown that. This is one of the key steps for detecting which is your first choice of treatment, like most of you are asking where to start, how to start. So identify the true axial myopia. For we need to do multiple tests, the comprehensive eye examination to rule out the baseline refraction. We need to do the accommodative lag, dynamic retinoscopy. So look for they are associated with any lag of accommodation. And we need to do this myopia battery test, axial length, peripheral reflection, corneal topography, pupil size will guide you which kind of treatment should be your baseline, and they start with the first line of treatment. We need to rule for the muscle violence like esophoria, high ACY ratio, they are the red flag for myopia progression. And we all know exophoric or intermittent divergence squint, how they are closely associated with the myopia progression. We need to perform some of the technical things to rule out there are any association and there are any defects, so we can rule out for the progression. So on the basis of everything, we can come out with the determine the myopia progression, and then we need to start your anti-myopia therapy. So careful evaluating both the subjective and objective risk factor, we can develop effective treatment plan and significantly improve the patient outcome. So we can see from here, myopia treatment not just a number, we need to, there is a diversity in myopia progression patterns and associated risk factors. Individualized treatment is critical rather than solely depends upon the average or statistics. Each myopic child should be treated as unique cases. So on the basis of subjective objective information, we can start our first line of treatment. If patient kids having relative hyperopic defocus, we can first line treatment should be go for the defocus lenses. It will work better. If the patient is a myopic hyperopic defocus, we should start the low dose atropine, and most of the time if associated with the intermittent divergent squint, their deviation more than 15 to 20 prism, the low dose atropine will work quite well. If near esophagia, the first line treatment should be bifocal or accommodative block, then we can go for the progressive and EDOF lenses. We have a multiple option at the moment, and that option only for the axial, true axial myopia. Lifestyle modification, we go for the pre-myopes. We can have multiple options for the defocus lenses, just Rohit has spoke. Spectacle, contact lens, and orthokeratology, they all work on the peripheral hyperdefocus. And pharmacological, we have atropine, and not least, we have a light therapy in the pipeline. So coming to the pre-myopes, age, new term for the age match condition, usually at the particular age there should be kind of refraction. We need to look for age match refraction. If progressing faster than that, then it's a red flag, and then you can say this is going to be the future myopes. There is a year before the onset of myopia, there is a big change in refraction, and that could be the possibility. The decrease in axial length is not going to match with the decrease in length thickness is not going to match with the axial elongation, and that's the time it's going to be myopic. And we all know the parental myopia, like one parent is myopic, then is associated with the 33% and 3 times higher risk, or if both parents, then it's a 5 times higher risk. And if the kids is associated with the lack of accommodation, more excessive near work, and esophoric, they are going to be myopes in the future. For the clinical intervention, we have a multiple for the pre-myopes. The outdoor is one of the main things at the moment, and light intensity, you know, just now somebody just spoke, the outside light intensity is almost 30 times higher than the indoor, so it's one of the most impactful for the pre-myopes. Adaptive dioptric space, when we look at the inside, our adaptive dioptric space is totally different. We will go to the outside. Outdoor optical infinity, not only the fovea, on the periphery also they have a no defocus, and that's one of the reason the outdoor activity is so important. And we all know that dopamine release in the outdoor, and that will inhibit the axial elongation, and spectral composition is totally different outdoor, more blue light, and that all are associated with inhibit the axial length elongation. If having near work mode, we can always guide 20-20 rules. It's very important, and we can guide the kids to look more than 20 to 30 centimeter to reduce the hyperopic defocus on the fovea. If kids is associated pre-myopes, accommodative lag, and esophoria, we always go for the bifocal and executive lenses. They are quite good in the pre-myopes, and already Jason has done the low dose atropine for the pre-myopes, and the spectacle lenses are also available now to treat the pre-myopes. But I will, at this point of time, the outdoor is one of the best thing we can do it for the kids who are on the pre-myopes. So coming to the opticals measure, there's 2 hypotheses where it works. One is the accommodative lag, and another is the peripheral hyperopic defocus. So already Dr. Rohit has explained all this, so I will skip these slides. So when we look at the biometry and we'll see the corneal curvature is like that, we will go directly to the optical defocus lenses. They will work much better compared to the other intervention we are having. And we have a few choices for the optical correction, like a first generation where it works on accommodative lag theory, and second generation contact lens and orthokeratology all will work on the hyperopic defocus theory. So we'll go through it. So does the under correction it works? The 2 landmark clinical trials are done, and both have shown that the under correction will progress faster. So we should not under correct and over correct for the myopics. Coming to the single vision lenses provide no significant efficacy of myopia control, often used as the control in myopia control studies. There's 2 landmark studies have done for the progressive addition lenses. One is from Hong Kong and another from the COMET study from USA. One is from 2-year, another is the 3-year study, and both have shown that the impact is very low, 1/4 of the side effect of the myopia management. But the committee to come out with the subgroup analysis, as they have shown that those kids associated with the esophoric and accommodating lag, they had a better impact, and keeping in that, they did the second study and only recruited the neurosophoria and accommodative lag, but the impact size is pretty much similar to the previous study. The another executive bifocal study has done, and there's a randomized clinical trials where the single vision 1.5 executive bifocal or 1.5 executive bifocal with the 3 base prism have given, and that study has shown that the impact was quite meaningful compared to the previous addition lenses, progressive addition lenses. And we can see here the impact is almost 4 times higher compared to the progressive addition lenses, and this will give us one of the better clue why all the defocus lenses are working, because we can see here the executive bifocal has a more area of addition compared to the progressive addition lenses, and that could be the possible reason why they have a better impact. That's why all the defocus hyperopic lenses have a 360 degree of concentric rings, and they are working better than all the previous single vision multiple executive bifocal lenses. So all these lenses have a similar efficacy. Just now Rohit has spoke, so we can choose either of them. If they are associated with the hyperopic defocus, your first line of treatment should be go for the optical defocus lenses. They will work quite well. And one good thing with the hyperopic defocus lenses, most of the study till now, they haven't seen the rebound effect, but it's a bit of expensive compared to the other mode of treatment. I won't go for the details of how does it works, but look at this biometry where axial elongation is leading cause of the myopia compared to the flat corneal curvature. So in these cases, low dose atropine will work better compared to the other modalities. But the few landmarks study has done, and they have also the quite meaningful efficacy on the myopia control. But recently the Atlas study came, and they have done included ATOM 1 and ATOM 2 participant, and those people has never gone for the treatment, and 20 years after this treatment they shown the 25% of the kids had the similar efficacy. So one is the drawback of the low dose atropine for the longer time, and low dose atropine is easily available, less expensive compared to the other modalities we are having at the moment. So one key point I will say, look for the cause of myopia before you will start the treatment. It's not like randomly whatever you have in your pocket just start doing. That will be impact your myopia treatment, and the efficacy will be much better. Thank you.
Thank you. Any questions?
Oh, pre-myops, like your age associated myopic thing. Like somebody is 7 to 8 years of age and they have plano or maybe -0.5, -0.75, they are going to be progress faster, because usually 11 to 2 years of age the metropization will show you a normal 0.5, 0.75, 0.25 like that. So that's the pre-myops. This is a new term, age related thing, but usually you have biometry, then you can assess very well these kids, because before the onset of the myopia, the lens thickness is not going to compensate your axial length elongation. That is the key factor, so you can see how it's going to and how faster your myopia is going to progress. So you can, the Brian Holden has came out with that, all the now myopia master and all these things, you can keep all this factor and you can come out with this progression rate. And it's online also available. I can give you you can put it on your laptop and you can see the progression. There is a free online, the myopia masters are there.
Myopia masters?
Yeah. I will give you the online, so you can Google it and you can just keep it, the age, your parents are, all the history you can put, and will come out with the factor.
It is a website?
Yes.
Myopia masters.
I will give you the link.
Can you share the link?
I need to look for it. It's my laptop. I will give you.
From it all you said that maybe if the keratometers is on the higher side, then you would preferably go for the lenses first?
If your baseline keratometer, the cornea is steeper compared to the flat axial length, and we know all we know the corneal curvature is the prolate, center is the steeper, and periphery is the flatter, and that's causing your hyperopic defocus. And that's the treatment of your hyperopic defocus is working, so you can go for the hyperopic. It works much better. And you should not start, that's why you should know the peripheral refraction, and then you can choose your line, because almost we are doing in NUH, National University of Singapore, we have the open field autoretinal. Almost 30 to 35% of the kids, they have the myopic peripheral refraction. So if you start there, the hyperopic defocus lenses, it won't work. So you need to look for the cause, what's the cause of myopia, and then your intervention will work very well. So you need to look out the what's the cause of myopia. You should not treat the ROP baby, because your question was ROP, the myopia is coming from the curvature and lens thickness, not from the axial elongation. Otherwise, the primary open angle glaucoma kids, the congenital glaucoma, there is the axial elongation, not the. So we need to look for the cause, what's the cause of the myopia, and then you can treat. Definitely, the numbers will be different, whatever we are having 50, 60, 30% of our efficacy, intervention, all these things.
So thank you, Rohit, and I really think that this was very nice and also a very good way to think about each eye is individual and different from each other. Do you think as pupil is one of the factor when you selecting?
Yeah, it's a very important factor, because all the defocus lenses, your pupil size is 2 mm, 3 mm, 4 mm, is not going to work. So that's why the combination therapy, low atropine, you see all the orthokeratology, they will work better with the atropine, because they have a better area to go the light inside, and they will cause on the hyperopic defocus. So pupil size is one of the important factors we usually ignore in the clinic, but the first time if you are putting on the myopia intervention, you should look for the pupil size, because all their hyperopic defocus, orthokeratology, whatever the intervention, the optical design have, it works on the hyperopic. So your pupil size is small, the light is not going inside, definitely it won't work.
So you see, you mean to say that in different population where the pupil size is low.
I'm not talking about population, any age group, any kids you are putting, their pupil size should be more than 4 mm to 5 mm in between. It works better rather than 2 mm and 3 mm pupil size.
Can you use the low dose of atropine along with the?
That's why. So we'll put the low dose, it will mid-dilated people, thus this intervention will work better.
Yeah, there's another question.
0.01% will not dilate.
It will not like 1%, but definitely it has the impact on the pupil dilation. Yes, it will be there.
Yes, and thank you for your answer. I have the other question regarding the opticals interventions. So I could hear that from India, you guys have Celeste and DIMS and DOT, isn't it? Like DOT from Zeiss, sorry, K from Zeiss.
Dot
so
only I will use, it's not well proven, but any retinal, I think, and patient will insist, because I know it's working on the contrast, then I will suggest that only like having some kind of retinal issue and you still want for Cooper intervention, that point of time your dots will work better, because it's totally different ball game. It's not working on the hyperopic defocus lenses.
Sorry, my question is, well, in Vietnam where I'm practicing, there are many other copied design. So do you have the same problem, either in Taiwan or either in India? And how do you explain that to your patients when you have, well-evident ones, but it's very costly, like Stellest from Essilor or Mio's mask from Hoya? How about you dealing with other copied
I'm so
design?
sorry, Singapore don't have the cost effectiveness. People will easily buy the things over there. Whatever will prescribe, they will go for it. So
Yeah,
not much
so
idea.
I think Taiwan can share the same problem with us. Yeah. Yes, so
Yeah,
many.
in Taiwan, we have several, we have, because it's medical device, so it cannot have copy. But I know in China they have 200 kinds of copies. So if they, unfortunately, if they pursue this kind of glasses, maybe we know from those maybe have some effect. But we still needed to ask the children to go outdoor, because just now the speaker also saying that outdoor is most cheap, free. So if the cost, then any kind of lenses that we think the most cheaper is outdoor. The other is the 0.01 to 0.05% atropine. Then combination therapy. Then I think monitor is the most important. And I don't know in Singapore, but at least in Taiwan, the psychoplegic is the privilege of the ophthalmologist. So we needed to regular to monitor. even though if we have the AIOS2025, even though sometimes we were confused because the children have the normal growth curve. So every year, the individual difference is very much. But if you see the psychopressure diffraction, you can have a very good monitor the progression.
Yeah, I also want to share a little bit from Vietnam, where parents in Vietnam do not want their child to wear spec at all. So then, if you're considering cost effect comparatively between spectacle and orthokeratology, parents are willing to pay for orthokeratology, even they know that the price is a little bit higher initially. Because even when the lens had been maintaining over time, the price cost actually cheaper compared to we change the cell lens every 6 months or every 9 months. Yeah, so that is a problem that I'm facing right now in Vietnam, convincing the parents as well as the other eye care practitioners to start using something safer, like spectacles in control myopia.
Yeah, also keratology is also good. I think Dr. Lin from Taiwan also have many
Just,
good.
I will add one
yeah.
point. If orthokeratology you are going for your primary intervention, then the refractive error should be more than 3.5 to 4 diopter, because lower the power, it won't work because they don't have the peripheral steepening, so cause the hyperopic defocus. So you should be.
Well, there's a debate on that. The new type of lenses, not new type, the traditional type of lenses could not create a very high defocus power. However, the new type of the customized one can create, higher defocus one. And as we learn more about the pupil size, I think we should be very careful choosing our patient depending on the pupil size as well. And then, of course, I totally agree with going outdoor is the best way.
It's free.
But yesterday, isn't it, we are talking about something like RP patient will not show the sign at the initial stage. So then, if you ask those kids to go outdoors, actually provide a worse effect. Especially you add on atropine and then ask the child to go out. It's actually a combination of the worsening. So I really like your idea of customized and finding the root and the cause of the myopia progressions. But I also think that we need to be kind of having a holistic way of working collaboratively to think thoroughly for the child as well. Yeah, so that's just my comment.
Okay.
Thank you. Thank you.